Good morning, everyone. Today, Harshida Jani and I, Shruti Soni, would be talking about Hikikomori syndrome. Could you go to the next slide, please, Harshida? So, the term Hikikomori originating from Japan is a blend of the words hiki, which means to withdraw, and komori, which means to be inside, collectively referring to people who withdraw from society. It was coined in Japan in the 1990s to describe young adults who remained isolated in their homes for an extended period of time. It is not unique to Japan, it is experienced by people all over the world and it is on the rise. In Western countries, the symptoms are usually associated with acute social anxiety or antisocial personality. Before delving into the details about the global rise of hikikomori, we'll first understand the basics. Could you please go to the next slide, Harshita? Thank you. Hikikomori is diagnosed when a person exhibits extreme social avoidance behaviors for at least 6 months, resulting in distress and dysfunction. These behaviors include refusing to leave the house, refusing to go to work, school, or college, and withdrawing from social interactions. Next slide, Harshita. The intensity of it varies among people. There are typically three intensities. People with mild intensity cases leave their homes 2 to 3 times weekly. Those with moderate intensity cases once a week, and those with severe intensity cases rarely leave a room. The probable comorbidities are autism spectrum disorder, mood disorder, psychotic disorders, and personality disorders. These are disorders which could be associated with this syndrome. Many practitioners report that patients acquire hikikomori after a stressful incident prompts new socially avoidant behavior. Next slide, please. Thank you. Hikikomori syndrome has a number of causes that can simply be divided into three categories: individual, family, and social. With respect to the individual aspects, personality traits play an important role. People with introverted, perfectionist, or avoidant personality qualities may be more vulnerable to hikikomori. They may have difficulty coping with social expectations and pressures. Then comes dysfunctional cognitive patterns such as excessive self criticism, poor self perception, and a proclivity to overanalyze social interactions can all contribute to hikikomori. These cognitive errors can lead to a vicious cycle of withdrawal and increased isolation. Hikikomori is frequently linked to conditions such as depression, anxiety, and social phobia. These mental health issues might make social interactions overwhelming. Coming to the family factors, dysfunctional family relationships, lack of emotional support, or conflict within the family can drive an individual to seek isolation as an escape. The second is attachment. Attachment styles formed in childhood significantly influence how individuals cope with stress, relationships, and social interactions. Insecure attachment styles, shaped by various family dynamics, can predispose individuals to social withdrawal and hikikomori. Next is family mistreatment. Family mistreatment, including emotional and physical abuse and neglect, can significantly contribute to the development of hikikomori syndrome. Such mistreatment erodes self esteem, fosters anxiety and depression, and creates a pervasive sense of fear and mistrust. These psychological impacts lead individuals to withdraw from social interactions as a means of social self protection. Then comes the social factors. First is collective loneliness. The massive spread of social media can lead to increased collective loneliness, contributing to hikikomori. Social media fosters superficial connections, exacerbates feelings of inadequacy through constant comparison, and reduces face to face interactions. This leads to diminished social skills and confidence, making real life socializing daunting. Seeking online validation and escaping from real life challenges further reinforce isolation, driving individuals to withdraw completely. Second is negative experiences. Negative experiences can cause individuals to withdraw from society. Bullying, rejection, and social humiliation create deep emotional scars, fostering a fear of further negative interactions. This results in a preference for isolation as a protective mechanism. Additionally, these experiences can diminish social skills and confidence, making social situations increasingly daunting and reinforcing the desire to retreat from social life. Third is economic changes. Economic instability, unemployment, and job insecurity can lead to feelings of hopelessness and withdrawal from societal participation. Harshada will carry on.
Right. So I'll be speaking about the research done on global trends on Hikikomori syndrome. So the first study conducted by Koyama et al. In 2008 investigated the lifetime prevalence, the psychiatric comorbidity, and demographic correlates of Hikikomori in Japan. The study involved a face-to-face household survey with 4,000 community residents aged 20 to 49. The primary focus of the study was to determine the prevalence and associated factors of hikikomori in this population. The survey revealed that the lifetime prevalence of hikikomori among the community residents was about 1%, and the prevalence was particularly high among respondents in their 20s, reaching about 2%. Approximately 0.5% respondents reported that at least one child in their family was currently experiencing hikikomori. And when extrapolated to the entire population of Japan, this suggests that around 232,000 people are currently affected by it. Among those who identified with hikikomori, about 54.5% had also experienced a psychiatric disorder at some point in their lives. These disorders included mood, anxiety, impulse control, and substance related disorders. The study found that individuals with hikikomori had 6.1 times the higher risk of developing a mood disorder compared to those without hikikomori. And despite the significant overlap with the psychiatric disorders, about half of the hikikomori cases were considered primary hikikomori, meaning that they did not have comorbid psychiatric disorders. On an average, the duration of the episodes of hikikomori were about 1 year, and the peak age of onset was between 15 and 19 years of age. The study also noted the lifetime prevalence of hikikomori being higher in males than females. The second study conducted was by Kato et al. In 2011, which explored the existence and characteristics of Hikikomori syndrome outside of Japan. So, this study involved psychiatric residents and psychiatrists from 9 countries: Australia, Bangladesh, India, Iran, Japan, Korea, Taiwan, Thailand, and the USA. The participants were given 2 case vignettes of hikikomori and filled out an anonymous questionnaire. And the questionnaire addressed various aspects of the syndrome, like the prevalence in their countries, the etiology, diagnosis, treatment, etc. Respondents from all the 9 countries reported the presence of hikikomori like cases in their country, and especially in the urban areas. This suggested that the syndrome is not only limited to Japan but is seen globally. And the presence of hikikomori in these diverse regions was thought to be associated with rapid global socio-cultural changes, which included factors like increased urbanization and changes in societal expectations. The respondents identified biopsychosocial, cultural, and environmental factors as probable causes of hikikomori, and the differences in the causes cited among these countries were not really significant, indicating a common understanding of the syndrome's multifaceted nature. The treatment approach in Japan suggested the psychiatrists wanted suggested treatment in outpatient wards, while some believing that a psychiatric treatment is not necessary. This reflected a more conservative approach to managing hikikomori in Japan, whereas in psychiatrists of other countries they favored more active treatment methods like hospitalization. This difference highlights the varying perspectives on the severity of management of hikikomori across different cultures. The next is the treatment for hikikomori syndrome. So there are various interventions that can be used to treat hikikomori. The first one is cognitive behavioral therapy. CBT is widely used intervention for hikikomori. It focuses on identifying and changing the negative thought patterns and behaviors. For hikikomori individuals, CBT can help address their irrational fears and beliefs that contribute to their social withdrawal, gradually encouraging more positive social interactions and coping strategies. Second is family therapy. It involves the entire family in the treatment process. It aims to improve the family dynamics and communication. For hikikomori, family therapy helps address any familial issues that may contribute to the condition and educate family members on how to support their loved ones' reintegration into society. Third is exposure therapy. Exposure therapy involves gradually exposing the individuals to feared social situations in a controlled manner. For those with hikikomori syndrome, this can mean starting with small, manageable social interactions and slowly increasing their level of exposure as they become more comfortable, thereby reducing their anxiety and avoidance behaviors. Then there's pharmacotherapy. Pharmacotherapy involves the use of medication to manage symptoms associated with hikikomori, like anxiety and depression. While it's not a standalone treatment, it can be an important component of a comprehensive treatment plan, helping individuals to be more receptive to other forms of therapy. Then there's a support groups. These support groups provide a safe space for the individuals with hikikomori to share their experiences and challenges with others who understand the situation. These groups offer emotional support, they reduce feelings of isolation, and can serve as a stepping stone towards broader social engagement. There's social skills training. Social skills training teaches essential interpersonal skills needed for effective communication and interaction. For these individuals, the training can build confidence and competence in social situations, helping them gradually re engage with society and form meaningful relationships. Vocational training. Vocational training helps these individuals develop job related skill and find employment. It focuses on building self efficacy and independence, which are crucial for their reintegration into society. These vocational training programs may also include job placement assistance and ongoing support in the workplace. Then there's community outreach programs. These community outreach programs offer a range of services to assist these individuals. The programs often provide counseling, social activities, home visits, and practical support. They aim to reduce the isolation by helping individuals develop social connections and access resources within the community. So, Hikikomori requires a multifaceted approach, which is effective and necessary. Then the conclusion. So, the social phenomenon of hikikomori is in Japan characterized by the extreme social withdrawal and isolation. Hikikomori is observed across the globe in diverse cultures and economic backgrounds in this digital age. An effective treatment of hikikomori involves a multifaceted approach to ensure the sustained recovery and reintegration of the individuals with hikikomori into society. So, we have a quiz for everyone. So, the first question is, what is hikikomori? A clinical diagnosis recognized worldwide for individuals with acute social anxiety, a Japanese term describing individuals who withdraw from society, C, an exclusively Japanese phenomenon observed in young adults, or a condition with antisocial personality disorder. Yes, everyone's correct. The answer is B. All right. So the second question, what are the comorbidities associated with Hikikomori syndrome? Psychotic disorders, mood disorders, personality disorders, or all of the above? Yes, the answer is D. All right. The next question. The prevalence of Hikikomori syndrome is more in women than men. A true, B false. Yes, the answer is D. All right. The fourth question. Which of the following is not a treatment for Hikikomori syndrome? Cognitive behavior therapy, exposure therapy, solution focused brief therapy, and D, family therapy. Yes, the correct answer is C. Thank you.